All right, well, thank you all for coming. This symposium is virtual care for the serious mental illness population. I'll quickly introduce myself. My name is John Taylor. I'm a psychiatrist based out of Boston. In addition to being an attending psychiatrist at Mass General Hospital and on the faculty of Harvard Medical School, I'm also Vice President of Population Health and Executive Medical Director at Author Health, which is a startup company seeking to provide care to seniors with SMI. We launched in March of this year, and we're currently treating patients in South Florida. So we're really excited to give this talk because this is a really underserved, under-recognized population, particularly where applications of technology come in. And so our first speaker is going to be Dr. Feyza Marouf. Let me give you a quick bio on Feyza. Dr. Marouf is a geriatric psychiatrist who recently became Executive Medical Director in Geriatrics at Author Health. She spent most of her career at MGH, Mass General, as a passionate clinician, educator, and mentor, leading interdisciplinary teams across varied treatment settings, and serving as the MGB, Mass General Brigham, Fellowship Director in Geriatric Psychiatry. As medical director at the Boston Center for Memory, she oversaw multiple industry-sponsored clinical research trials in mild cognitive impairment and Alzheimer's dementia. At Author Health, she is committed to driving innovations in mental health care for older adults with severe mental illness and dementia and their caregivers and families.
So my talk will be quite clinically focused. And I wanted to say, anyone who has questions during the course of the talk, please, this is a small group, please feel free to just ask questions if they come up along the way. Can everyone hear me okay? So COVID-19 was a crash course in telepsychiatry. It felt like in clinics, everything changed overnight. We went from probably doing about 2 to 5% telepsychiatry visits to pretty much the entire outpatient clinic functioning that way. And, sort of at the insurance end of things, there was an expansion of reimbursement to meet that need. And there was a quick move towards figuring out what platforms would be secure to keep confidentiality for patients. In inpatient care, there was a lot of mobilization just to construct a platform so that patients could communicate with attendings, sometimes through a nurse. So there were a lot of mobile iPads that would go into rooms that required a lot of staff training pretty much overnight in terms of thinking about a hybrid model of care where one nurse might be able to go from room to room and communicate that to a team of doctors. There was a lot of mass communication that made it hard for many older adults to be able to do things like lip read. So patients who were hard of hearing and had relied on being able to lip read as a primary means of communication, it suddenly became quite aware, I would say, during the pandemic that was much more difficult. In outpatient care, there was a lot of back and forth between video and audio visits and thinking about some patients really preferring the phone and having no access to the internet or having the ability to connect by video. And almost everything happened virtually, except for things like the delivery of a long-acting injectable or intensive assertive community treatment. So at MGH, a lot of the challenges we faced with were figuring out, sort of how to make sure patients were comfortable with technology, how to deal with the anxiety and the frustration that a lot of patients felt, and I would say also providers. This was sort of a joint transition in terms of difficulty using devices, needing assistance, setting things up, figuring out technical issues. A lot of patients struggled with, the visuals dropping out or being delayed in the course of an appointment, and a lot of that had to do with bandwidth. A lot of times sensory issues came up during outpatient visits in terms of not being able to see clearly or not being able to hear the provider. And for folks who had cognitive impairment, who were living alone and who needed their caregiver for coordination, when that caregiver was not there, it became almost impossible to facilitate an outpatient visit. And it really, I think, revealed to us the enormity of the digital divide. The idea that for many vulnerable populations, those who might be lower income, those who are older, those who are located in rural or tribal lands, the internet wasn't a given, and it wasn't really always possible to be able to bridge that divide. So thinking about, what was our strategy in terms of thinking about working with older adults virtually? A lot of times, like putting some time into understanding first, pre-visit, what type of technology patients had access to. Did they have a smartphone or an iPad or a computer? Could they connect by video? What was the quality of the video? Or were they more audio-only patients? And what kind of broadband access they had. And it was also important to figure out, in an emergency situation, what would be our protocol? How could we confirm the patient's location? How could we identify the emergency contact and have a backup plan if the technology failed? One thing that was surprising, I think, to most of us with regards to older adults in telepsychiatry was that it worked. There were high satisfaction ratings. Treatment seemed just as effective as in-person treatment. Clinical measures, cognitive testing was reliable and valid. And there was equivalent diagnostic accuracy across different types of illness, from depression to anxiety to psychosis and substance use, cognitive and personality disorders. And I think for most of us who felt that the inpatient encounter was pretty unique with older adults, it was really remarkable to see that transition happen as fluently as it did. We know much less about emergency room care and inpatient care from studies, but by and large, the care there was just as acceptable as it had been pre-pandemic. The question also came up of, is a phone call preferable for some older adults with mental illness? This was a study done at McLean, looking at outpatients who needed assistance with Zoom, where only 53%, 53% needed assistance, and only half of those had a caregiver able to assist them. So thinking about where is the phone best, I would say a lot of times for initial evaluations, a phone is less optimal than it would be for a follow-up appointment where there's already some traction and an established relationship. And sometimes the phone is best for reviewing a test result or an imaging study, or thinking about a medication change and refill. The first case I want to present is Peter, who was a virtual-only patient in private practice. And Peter was a 78-year-old married man, former carpenter, with severe major depression and generalized anxiety. He had insomnia, and he had a lot of subjective cognitive complaints. He had a lot of increased back pain as well that limited his ability to do things that he loved, like working on home projects and being in the garden. He had already been seen in a memory clinic for a full cognitive evaluation with no evidence of dementia. He did have a family history of a mother with alcohol use and dementia. And he had described that he had a lot of difficulty traveling from the rural area in Massachusetts where he lived to his appointments, and became really stressed by driving on the highway and generally avoided doctors. He also described a lot of recent losses, that his sister had recently died during the pandemic, that he had retired from his carpentry business, and that a lot of friends had moved south to Florida. The themes that came up in our treatment included the difficulty coping with aging, the vulnerability of aging and that he was feeling, and the difficulty with trust. Peter had a lot of difficulty expressing himself, especially emotionally, and had a lot of suspicion and mistrust that was at first somewhat difficult to characterize and separate from paranoia. When we started treatment and video visits, he initially had a lot of difficulty due to the technological difficulties of just setting up the visits. And his wife became involved and helped kind of sort of bridge that trouble. Together, we tried several antidepressant trials. We worked on his sleep. We worked in supportive psychotherapy. And his wife frequently joined us for couple sessions. There were a lot of ways that we overcame barriers in his treatment in terms of his wife being there as a caregiver. And that allowed a lot of mobilization of his emotion that only increased as the medications took effect and became less depressed. And overall, there was a significant improvement in his mood and his sleep pattern with medicine, and he did accept referral to virtual treatment with a social worker. A different case was Janice, who had depression and dementia. She was an 84-year-old woman, very resilient, former singer and drug counselor, who had gone through a very difficult and severe assault when she was younger. Her PTSD, though, had been in remission for years, and she was living with a much younger second husband who was still working. Her daughter lived nearby. She enjoyed spending time in thrift shops where she was a volunteer, but felt very socially isolated and unable to do meaningful work, and really missed the days when she had been able to be a drug and alcohol counselor. And she had a family history of siblings who had lived into their 90s. Janice came to see me for worsening anxiety in the setting of aging. Her family was very concerned that there was a recurrence of her PTSD in the setting, and the anxiety might be related to that. And she had been through a lot of psychotherapy in the past and had been previously stable on her medication. And so there was a lot of thought about the vulnerability that she was experiencing as she aged, and that her resilience itself was waning. There was increased conflict with her husband over where to live, the wish for more social contacts. As she described, the ladies were here to say hello, but no one ever tries to get to know me. The format of our therapy was through video visits. And again, technical difficulties that were resolved by help from her daughter who lived nearby. The interventions were similar. We adjusted her medicines for her mood, for her tremor. So we had supportive psychotherapy focused on coping with aging and with changes in her social networks. And we worked on exercising daily and building more social connections. Yet, over the next 6 months, she continued to have episodes of fluctuating tearfulness and mood lability, decreased emotional tolerance, partial benefit from the medicines, but a lot of forgetfulness. And she said to me, "I'm starting to feel desperate." So I made the decision to do a home visit with her in order to do some cognitive testing together, which technically can happen equally well sort of over the internet. But part of the reason I wanted to see her was to have a family meeting with her daughter as well, and to really discuss what might be going on with her. Her MoCA score was a 23 out of 30, which was significant enough in terms of only remembering 0 out of 5 words in 5 minutes and having really difficulty with drawing and other visual spatial abilities. The family meeting really focused on the fact that her lease was coming up and what best next steps there might be for housing for her in the future. Was the home visit necessary? Was a question that we asked ourselves a lot in terms of when do we cross over from purely virtual care to actually stepping in with a patient in their home. There was no way to discount that it was more comprehensive care. I could really assess her environment. You know, she showed me where she used to have a rocking chair, and we thought together about, actually, maybe this would be helpful in terms of soothing her anxiety. I realized that the stairs to her second floor were extremely steep, and that although she had told me about that, I hadn't really understood how difficult it was for her to go up and down. And the disorder in her home was much more apparent in person than it had been by video. And she described, you know, I kind of try to keep tidy, but the mail just keeps coming. And I also was able to see where she kept her medicines in her kitchen. You know, and she said, "Those are my pill bottles over there." And I realized, like, she probably wasn't taking them in the same way, and that part of the problem was she was taking the medicines out of each bottle every day and was having a harder time remembering what she had taken, and was likely both under and overdosing. So I could also evaluate her physically much more closely. I could look at her gait. I could figure out if her gait was stable, whether her tremor was as bad as it looked on video, and what her vision was like in terms of engaging with me. And moreover, I could provide reassurance and explanation much more personally. You know, it was a closer social connection in the midst of so much isolation that she was already feeling. And it made me think about, what do we miss when we don't see patients in person? For instance, you know, a lot of patients who are self-neglecting and who might have a body odor, or patients who are drinking more than they report, and you get a kind of little smell of alcohol when they come into the office. Patients who are actually much more unstable on their feet than they might appear when they're sitting down. And patients who have a really hard time hearing that they can get away with in the office by reading lips or by pretending. And it's also very hard to really figure out if there's anything physical that's changed with the patient. So have they had a dip in their blood pressure? Is there something else that's going on with their heart rate? Is there something else physical that's happening in that moment that we can't really assess immediately virtually? How do we prepare for visits with cognitively impaired patients? I think that it often requires a lot more coordination with the caregiver ahead of time. It's important to ask the patient if they'd like to have a family member or caregiver participate and help during the appointment. It helps to have the caregiver there to help a patient get online and to troubleshoot tech challenges and to facilitate the conversation itself. It's also really important to think about the extra time that it takes in that clinical encounter in order for the patient to get online. What that transition was like to think about moving from a virtual only treatment to a hybrid model of psychiatric care took place on both outpatient and inpatient levels. In the outpatient setting, the remote psychiatrist could also make home visits. The remote psychiatrist could work with a team, a member, making a home visit. Or asynchronously, a team member could make that home visit, relay the information to the virtual psychiatrist, who could have an appointment later. On an inpatient basis, the remote psychiatrist could coordinate with a team based on the inpatient unit, or the psychiatrist could move between an outpatient setting of being remote or also being on the unit part-time. One model of how this worked was at Neshoba Valley Inpatient Geriatric Psychiatry Unit, which was a community hospital with a 20-bed unit for adults who are older than 55 and have either severe mental illness or dementia. And there they used a really collaborative care model that included a program director and nurse on the unit, a number of social workers and nurses' aides, an activities coordinator, nurse practitioners, and physical assistants who would meet in a daily rounds. And with them, the psychiatrist would be integrated remotely. And the nurse supervisor was really the point of contact for those virtual rounds, taking the iPad again from room to room, and conducting the physical examination of the patients when needed, where the remote psychiatrist was entering in the notes and the orders from home. A different model is the one now at Author Health, also with older adults with severe mental illness, also with adults who have cognitive impairment and dementia, led with a multidisciplinary team approach that's virtual first, meaning that most of the team is in a virtual setting, but on the ground is a community health worker who makes in-person health visits and can use that visit to show through technology exactly what's happening in the home environment, how to reconcile the medications, and how to improve communication with the patient. There are a lot of barriers that are overcome through this model. The first is just the access to the internet. We do a tech check as part of enrollment and tech enablement by bringing technology into the home. There's early identification of interpreter need. We have a diverse community of health workers who make those home visits, and there's a lot of matching in terms of language and culture. The MOCA screen is a detailed consent. It begins with a detailed consent process. And in terms of care coordination, there's a lot of help both between the community health worker on the ground and the care manager to organize and support the patient with a number of resources in the community. I wanted to just share some quotes about what it's like to be the community health worker. And so these are notes from the record from the community health workers' point of view. I arrived to assist with technology independence. A family member opened the door and went back to bed. I walked over to the room where the patient was located. I connected the patient with the medical assistant virtually. In the midst of being connected with the medical assistant, a family friend who's the current caregiver joined the appointment. I sat nearby to assure that no interruptions occurred during the visit. The caregiver stated to me that she's responsible for the patient's medications, but needed a lot of assistance with transportation and getting a home health aide. The patient's feet appeared to be extremely swollen, and her arms were as well. The patient stated she is not taking medicines for the swelling and has not seen a provider due to being bedbound. These were all very helpful observations on the part of the community health worker. And they also were significant in terms of troubleshooting, figuring out who was in the home, how the connection happened, how to facilitate the appointment, and what kinds of questions and problems someone might have. Remarkably, a lot of the requests that patients will have or caregivers will have are not directly transmitted to the doctors or nurse practitioners on a team as readily as they are to community health workers or other kind of team members who engage with patient caregivers in more informal ways. And I think that this model is worth thinking about in terms of when we step back and look at what are the best models for older adults with severe mental illness. There are a number of different ways to think about it. One is if we just work in person only, what are the barriers? And the major barriers are often mobility, just being able to bring a walker into a hospital or a clinic, or the difficulty with transportation and the cost of transportation, the cost of parking, entering a complex hospital, the lack of flexibility with appointment times, often being given a time and not really having a lot of choice over when it can happen. The complexity also of just entering a hospital and trying to make it through elevators or through a busy clinic and sitting in a waiting room, all of that can be overwhelming to an older adult with severe mental illness or dementia. So thinking about for virtual care that is much more conducive to overcoming those barriers for an older adult, there can still be some drawbacks in terms of a limited understanding of the environment, or a static view of the patient where you can't really conduct a medical or physical eval in the same way. Much more need for technological assistance and for help with just connecting online. And that's different from hybrid care, right? So thinking about a remote psychiatrist and an in-person team, a model that really tends to work best on an inpatient basis. And thinking about a virtual first model like Author in terms of a remote team and an in-person community health worker as much easier to facilitate outpatient care.
I'll say it again for the recording. You make a convincing case, but how do we tell what works when? And how are you measuring your impact and comparing it to the other models you've talked about?
That's great. So one of the things that we're working on at Author is to figure out which measures are the most representative of change for different patient types. So for a group like dementia care, I would say quality of life measures are often the best measure of the overall outcome for the patient, versus for sort of looking at the same measures we would use in younger adults for severe depression in terms of their PHQ-9 score or their GAD-7 score for anxiety. And also thinking about caregiver burden as a separate measure, so that we know that when caregiver burden decreases, we will probably use the Zarit burden, we know that the overall system improves. So as caregiver stress goes down, patient outcomes improve. A lot of times the outcomes that we look at have to do with trips to the ER, trips to the inpatient hospitalizations, use of sort of high-risk medications. And again, that can often reflect the confusion at home in terms of what to take, how to take it. And thinking about sort of the overall impact on the system for the patient that includes the caregiver and includes their physical health. So another aspect of our quality initiative is to look at how are patients doing in terms of their medical care, their ability to keep up with their diabetes or their hypertension, treatments through kind of looking at some of the lab values and tracking those to see how well patients are actually adhering to treatment. But that it is more data collection, I would say, than happens in most outpatient clinics. Any other questions?
Okay, so I'd like to talk about using data in population health, specifically for the older adult population with serious mental illness. And I think a good first question to ask is, what are we trying to do with this population? So when we stop thinking about patients as a single person coming through the door to your clinic, and about a population of patients who are probably not coming through any door, because if they were coming through a door, they wouldn't be on your radar to try to enlist in care, right? What are we trying to do with these folks? We're trying to keep them healthy. And so what does that mean? It means basically three things. You are trying to decrease their illness burden. You're trying to keep them home, right, out of the hospital, and you're trying to keep them engaged, because if they fall out of care, they're likely to become unhealthy again. And so what I'm trying to do in this part of the talk is think through how we use data to inform keeping people healthy. So when you're thinking about population health, the first step is really to quantify what the opportunity is with your population. So I'm going to be talking specifically about older adults with SMI. So, the first step is why would we focus on this population? So the literature tells us that total cost of care for Medicare Advantage members with SMI is 2 to 3 times greater than that of the general population. And for health plans, their loss ratio typically is over 100% on these folks. And so what that means is that the loss ratio, just to define for folks who aren't in the know, is the amount of a premium that is spent on health. So if you have an 80% loss ratio, that means 80% of the patient's money per month is spent on healthcare, and 20% is spent on overhead, right? If it's more than 100%, you are essentially losing money on the patient. And so it also makes these folks undesirable to care for when you're an at-risk PCP group or a health insurance plan, because it's very hard for them to move the needle on older adults with SMI and SMI generally. And so what you want to do, or what we want to do, is help make the case that we can improve that medical loss ratio through reduction in total cost of care, unnecessary total cost of care, right? And then through accurate diagnosis and treatment. So the hypothesis, right, is that there's a lot of unnecessary spend in this population because they are getting poor care or getting no care, and they're probably misdiagnosed or underdiagnosed. And I think like that has face validity if there are clinicians in the crowd, right? So then you need to kind of quantify like what is the opportunity here. So if you look at the lower left table, so for Medicare Advantage members with no SMI, their risk-adjusted score for CMS is about 0.85, and their annual inpatient utilization per 1,000 patients is 125 visits, and their inpatient cost is $8,000. For the population with SMI, we see that their risk score is double. Their PMPM is about 2.5 greater. The inpatient utilization is, 6 times greater, and then their inpatient cost per admission is 1.5 times greater. And so in some ways, the case to focus on this population is easy to make once you have the data to do so. And so then what do you try to do? So up in the, on the right-hand side are sensitivity tables to try to make the case for like, why, first of all, why this population, but also like with expected levels of engagement and reduction in unnecessary healthcare utilization, like what kind of impact could a company like ours expect to make? So the way you would read this is in the upper left of the upper right. So 2.4%. That means that if we were able to engage 10% of a population with seniors with SMI and reduce their utilization by 5%, we would expect a savings of 2.4%, right? And so when you play that out in the lower table with dollar amounts, so if you have a population of 5,000 lives and you are able to really like knock it out of the park and get 30% engaged and reduce their overall utilization by 25%, you would expect an annual savings of about $11.5 million. And so the first step is essentially getting like data, first of all, looking at the literature and then getting good data from your partner who you then want to like perform this intervention with. Okay, questions about any of this? Okay. Ipsit, you look like you have a question.
I'm just, that was a lot of math in a short amount of time, and I'm under-caffeinated.
Sorry.
No, it was. Can you walk us through the last table again? I'm trying to keep pace.
Yeah, so what we're looking at is
the gross savings per 5K lives table.
Right, which is the same as the above, it's just dollars instead of percentages. But basically, so there's an expectation that you would engage X percent of patients, and that's the vertical, right? So 10%, 20%, 30%. And then with your engagement, with your engaged population, you would expect to reduce their healthcare utilization, i.e. inpatient and ED use, right, by 5, 15, 25%. And that's how you get to those numbers, yep. Okay.
And that's over a year?
Yes. Okay. So that's like big picture population. Then what you do is you get the population from your partner, right? So you would be assigned, you know, X number of people. It could be hundreds, it could be thousands, it could be much larger than that. And then you need to use data to really identify who you want to make an intervention on. So let's say your population is just like psychiatric illness. And then from there you need to figure out like who do we want to intervene on. So you get like, you know, the number of psychiatric claims, whatever data they give you, right? Patients with psychiatric diagnoses and their claims and whatever they can give you. And you realize this is an enormous population and not all of them are going to be high spend patients. And so then you need to sort of discern who in this population is it worth making an intervention on because there is an impact to be made, right? So if we applied our very high touch model to every psychiatric patient out there, like that would, first of all, that would be impossible, but also it would not be like a cost-effective use of resources, right? So like it is then incumbent on us to figure out like who are the like highest spend patients, and also are those impacts possible, or sorry, are the reasons for that high spend impactable by by the model that we want to create, right? And so you can examine patterns in health records and look at like, utilization. You can look at their comorbidities. You can look at the number of, or the amount of polypharmacy. You can look at the number of diagnoses they have, medical or psychiatric. But from there, what you want to do is sort of figure out like who are these people and who do we choose to intervene on. And so sort of the next step is figuring out then who do you want to outreach to. So when one gets data from a partner, like a payer or an at-risk primary care group who you'd be working with, it's raw and it's incomplete. Lots of the data doesn't have an address or a correct address or a phone number, right, or an email address. And so it then becomes the challenge to actually like get data that allows you to then perform an outreach on a hard-to-reach population. And so you can leverage data partners who can, using publicly available databases, then sort of like complete the rest of the picture for the patient population. And so through those partners and those services, we can get everything from the correct address and their phone number, which is obviously like a great starting point. But like, what else can you learn? You can learn who else is in the household. Are they the same age as the patient? Is it the patient's children as well, right? Do they subscribe to broadband internet? Do they have a cell phone? You might also be able to find out, do they answer their phone when you call? What zip code are they in? Are they in a house, a building? All these sort of things that then influence like your decisions on like who is it worth intervening on. And then you try to stratify the population, which is kind of what I was explaining. And so through the enriched data, you then sort of can use, narrow the population further by using data from health information exchanges and claims. And so that from there you can figure out like who has been in the ED in the last 90 days, year, 2 years. How many claims do they have? What were they for? How long were the hospitalizations? And so on. And so with that, we can figure out like who is most optimal to reach. And then kind of the last step is like, what is the outreach? So for us, it's multifaceted. It includes phone calls, it includes emails, it can include text messages, it can include the community health workers going to the patient's home and trying to engage them in that way. And not just their home, it can involve going to their church, their community center. We meet patients at their primary care office when they have an appointment, so that we can have like some version of a warm handoff to establish trust. And so, in performing all these interventions, we typically start from like low touch to high touch, but the goal is to figure out like who needs high touch off the bat, again, using a data-driven approach. Questions about that? Okay. And so then like what is the approach? What is the care model? So this is a very busy slide, so apologies, but essentially like this is at a really high level like what we're trying to do at Author Health. So this is sort of the post-data clinical care part of things. So what we do is we attempt to triage patients based on all of the data that we already have, and figure out, like, first of all, what kind of clinician do they need to see initially? Should it be a doctor? Should it be a nurse practitioner? Could it just be community health worker involvement? And we make this decision based on prior higher level of care utilization, whether we have any like lab or PHQ-9 data or anything like that from the PCP, and then they have an intake with the appropriate clinician, and then from there we stratify them based on the clinician's discernment and also recent healthcare utilization, and sort of triage them into like low, moderate, severe levels of complexity. And then from there, figure out like what kind of care they're going to get. So if they're low, which as an aside, we are treating SMI, but we've told PCPs to send this everybody because primary care doctors are not going to be great at discerning who has SMI and who doesn't. And so we want to take that off their plate. So what we do is see everybody, and then if they're low acuity, like they just have mild depression or generalized anxiety disorder, we see them once, we give some recommendations, we send them back to the PCP, we can do e-consults in the background if there's like further questions. Versus for mild to moderate or severe, we take them into our care model. And so in our care model, we have a fairly large team of folks who all come together to like figure out what's going on with this patient and deliver quick solutions. So we have a stable of psychiatrists and NPs who provide diagnostic assessments, medication management. They work with patients and their caregivers. We have LCSWs who perform psychotherapy. They also provide caregiver support to folks with dementia and other patients family members of patients who have, for example, psychotic disorders. We have behavioral health care managers who sort of help wrangle the team and write care plans and come up with and act on solutions to problems. We have community health workers who, as Feyza was mentioning, they go to the patient's home, they facilitate virtual visits with an iPad if need be. They help patients become technologically independent when possible. They also perform social needs assessments. Every one of our patients gets the AHCHRSN, and that informs then what social determinants of health interventions we can provide, such as helping folks with transportation issues, food insecurity, housing instability, and so on. Interestingly, also, the community health workers tend to be like the face of the company. They are the folks who the patients become like most attached to and are often their first point of contact and the voice they recognize. And then we also have pop health coordinators and medical assistants who help do some of the behind the scenes coordinating with primary care offices, making sure that like records from inpatient units and that kind of thing are like exchanged and like codified in the chart. And then also the medical assistants are the folks who kind of start the visits, they get the medication reconciliation, they answer any patient questions, they do a lot of phone calling, that kind of thing. And sorry, so this is kind of the team. Any questions about like the care model and the team and how we thought about that?
If I understood correctly,
Yep.
You're reversing the population health model. You're kind of starting with the big population level data and then distilling it towards the individual. Did I understand that correctly?
Yes.
Okay. Yeah. Haven't seen that before. That's novel.
Well, say how you think that's a reversal.
Well, we typically gather individual level data, get the population level data, and then public health sort of policies and procedures kind of stem from that. I can't recall an approach where we started with sort of well-defined population level data and sort of use that to refine how care is made more precise at the level of the individual. So
Yeah,
I'm just making sure I understood that correctly.
I think you do have it right, and I think, let me explain the reason for that. So what we know about this population, again, from claims data, is that they are not engaged. Like, the data we have shows that for seniors with an SMI diagnosis, like over 90% of them did not have a normal outpatient visit in the last 6 months. They had ED visits, right? But they didn't see like their PCP or frankly like any regular outpatient doctor. And so we have to start sort of at a higher level because half the battle, actually 90% of the battle with this population is just engaging them and like getting them through the door for that first visit. It's really challenging to, well, let me back up. The initial cohort of patients we were working with were referred to us in a more traditional manner. So PCP would see their patient, they'd realize this PHQ-9 is like really high, they'd think author health, they'd talk to the patient about author health, they'd refer them to us, and then we would sort of arrange for the intake. It's pretty traditional. The challenge of the reverse, right, is that PCPs have identified these folks as needing our help, but they're not engaged. And so you don't get that benefit of that warm handoff. You have to have an engagement strategy that makes sense for folks who aren't engaged. You need this like multimodal approach. You need people who are from their community because if we're hypothesizing reasons why people aren't engaged, it's because what? Let's see, healthcare is expensive, it's too hard to get to the doctor's office, they don't like taking medication, they've been treated poorly by the healthcare system before, right? The people who are treating them don't look like them, they don't speak their language, like all these reasons, right, that you then have to like overcome to both present yourself as like an entity that can help them and also establish trust, which is like doubly hard when you're a virtual first model and you can't just point to like, well, here, come to the building, it's author health. Like, we don't have that. And in fact, for the first 3 or 4 months we were doing this, we didn't have a website even. And so we're learning about how to engage a really challenging population. And that's why we're doing this the way we are. Other questions?
I'm tempted to ask, why did you start in Florida?
Oh, because our main partner has a huge senior population in Florida. There's no shortage of business in Florida if you're looking to treat elderly adults, right? But to that point, I will say, the density of folks in Florida means that we have a particular strategy with community health workers being in market and being able to like drive places. When you think of areas that are less urban than like greater Miami, right, or more far-flung, like the model probably has to change because you're driving hundreds of miles to reach people in like rural, I don't know, Montana, Minnesota, Arkansas, pick your state, is going to be really challenging. And so this is also part of why the data-driven approach is so important, because you need to figure out like where are your clusters of potential people to impact, and then like what are the boots on the ground resources you need to corral to like actually do it in a way that like is feasible.
Right, it's really about scale.
Yeah,
right? So
exactly. Yeah.
So the faces slide would have to change, or the filters.
Yeah.
You know what I mean?
Yeah. Yeah.
And, okay.
Yeah.
But like this gentleman said, I don't know the name. This is like the other way around for pretty much. Ipsit. Okay. Thank you.
Yeah.
So like Ipsit said, it's the other way around for pretty much what everybody else is doing. So hold up.
Yeah. And then quickly about a data platform, which is also really important for a data-driven approach, as you might imagine. So what do you need for this, right? So you need data, right, from your claims, from your EHR, from the HIE. You need a way to ingest the data, right? You need a data lake that allows you to like organize the data. You need to make the data into something that is usable through transforming it, right, by filtering the raw data into something that is able to be kind of stratified. You need data governance. So by that I mean you need to sort of define what you mean when you are looking at the data. So just as an example, if I asked all of you, how would you define an engaged patient? I would get a different answer out of every one of you, and that has been true in our company as well. And so we've had to sit down and like really define what do we mean when we say an engaged patient, because that is important for reporting when you're reporting on engaged patients and the impact you're making. And then consumption. So then you need a way to display things in a way that makes sense. It could be Power BI. We're using Looker, but you need a way to like make the data into dashboards that then become clinically usable by not just the clinical members of your team, but also product and technology and other people who are looking to, or operations, but looking to make an impact in their way on the patients. And then lastly is the important thing is evaluation. And so when you're doing these population level interventions, right, you're only going to impact a certain % of the patients, and you're going to impact them positively to an extent, as we saw in the sensitivity tables probably. And so you then need to figure out like how are you determining success? And so in a population like this, you might do a pre-post analysis. You could have a matched population who isn't being intervened on in a different geography, or you could match against patients who you kind of were assigned but who you weren't able to engage and see like how you move the needle against a matched population. But what you're probably going to look at is like, total cost of care, so ED and inpatient utilization, overall spend, and then for individual patients, you want to pick the metrics to track. And so do you have an infrastructure to regularly obtain patient-level data, such as PHQ-9s and GAD-7s and MoCAs and Zarets and all these other measures that we would want to get on patients to track that particular patient with this particular illness, right? And then display them in a dashboard, and so that way you can have like a pop-level view of like, okay, the overall team is able to decrease the PHQ-9 by like 8 points. But like I, as a clinician, want to know like, where's this patient going? Are they flattening out? Is the PHQ-9 going down? Are they actually getting worse? So you need ways to display both zoomed in and zoomed out data. And then the last thing I'll say here is you need a way to like determine whether your intervention is the one moving the needle on these patients, because what you'll find if you're doing this with a payer or a primary caregiver, whoever, is that you are one of like dozens of simultaneous initiatives happening, and if you don't think through this ahead of time and do it in a way that allows you to take credit for your work, you won't get credit for your work, and then it becomes really hard to say, well, we should expand, right? So when you're thinking about doing this as a pilot, to the degree that you can, I mean, we're in a real world situation, it's very hard, it's very messy, but you want to be able to demonstrate in some way like the impact that you as a group or company are making. Questions about this? Okay. Well, thank you. That's my last slide. And now let me introduce Elissa. Just one second. I have her bio on my phone because it's 2023. So our last presentation is from Dr. Elissa Kozlov. So Elissa Kozlov is a clinical psychologist and assistant professor in the Department of Health Behavior, Society, and Policy at the Rutgers School of Public Health and the director of the Population Aging Concentration. Dr. Kozlov has worked in clinical settings that serve older adults and adults with serious illness, including hospice, palliative care, cancer hospitals, nursing homes, and private practice. Dr. Kozlov's research focuses on improving psychological outcomes for older adults and adults with serious illness and their care partners. As part of this line of research, Dr. Kozlov has documented the gaps in mental health care within palliative care, as well as the trajectory and prevalence of depressive symptoms at the end of life. Dr. Kozlov has received grants from the NIH to develop and study novel tech-based interventions to improve mental health outcomes for older adults with serious illness and their care partners. Elissa.
Hello. Really happy to be here, and thank you. So this research was supported by some grants from the NIH. I want to present two main studies today. The first is not an older adult focused study, but it's an important study to give the context to the second study. So the first will be looking at the reach, use, and impact of a free mHealth mindfulness app in a general population. And then in the second study, we'll look at the feasibility, acceptability, and preliminary efficacy of an mHealth mindfulness therapy program for caregivers of adults with mild cognitive impairment. Just some background on mindfulness-based therapy. So mindfulness therapy is a pretty robust therapy with a lot of empiricism behind it. It helps us manage stress, depression, anxiety, and it does this by helping to increase your awareness of the present moment. I like to think of it as, anxious folk tend to be future-oriented. What's going to happen? What if? What if? Depressed folks tend to be past-oriented. These things are keeping me down. Healthy folk tend to be present-focused. And so that's sort of the mechanism behind mindfulness, at least hypothesized at this point. Traditional mindfulness therapy usually involves 8 or more hours of face-to-face treatment with trained professionals, which is not really a particularly realistic treatment option for so many populations, especially for an older adult or seriously ill population, because A, there are not enough trained professionals to provide this psychotherapy, B, there are time constraints and competing demands. When folks have serious illness, they might have multiple medical appointments, which tend to trump mental health needs. Not to mention, they might not feel well enough to make it to a face-to-face appointment on any given day. Their energy may be lacking. They may be having a symptom flare up. And there are reimbursement issues too. I think we all know that there's this big problem, especially for social workers and psychologists, to get appropriate reimbursement for services provided. So all of these barriers make it pretty hard to provide some of the traditional face-to-face evidence-based psychotherapies. But mHealth can overcome a lot of these barriers of traditional psychotherapy. I love that in the keynote, our speaker said, these mobile phones that are always within like 3 inches of our hands, even when we're sleeping, they're the most pervasive and ubiquitous technology, right? So how do we leverage them for good instead of all of those recent articles that are showing us about how they're destroying our brains and making us ruminate and feel more depressed all the time? So what can we do to change our relationship and view them as a mental health tool instead of a mental health detriment? So for this study, I worked with the Veteran Affairs National Center for PTSD. They have if you're not familiar with their mHealth suite of apps, they are a remarkable free resource for everyone. So they were developed by the Veterans Affairs National Center for PTSD. There are many apps, including Mindfulness Coach, that are not veterans specific nor PTSD specific. So they have a great CBTI coach. They have a great worry tracker. I forget what, a breathe to relax program. So like just a simple breathing tool. I love Mindfulness Coach. I think you can pay hundreds of dollars for Headspace or for Calm, or you can get this free app from the VA developed by psychologists with technologists. It's like there's not a lot of bells and whistles, but it's based off of the same in-person protocols that were used in the VA. And for anyone who's trained or worked in the VA, you know how robust and impressive their mental health program are. Yeah.
And they don't secretly collect your data.
And they don't secretly collect your data. I collect your data when you enroll in my research studies with the VA, but they do not collect your data. That is totally correct. So Mindfulness Coach, you can look at it now. I'm going to walk you through it really quickly. It's based off of a protocol specifically for folks who are not only new to mindfulness, but might be skeptical of mindfulness therapy. So it takes you through education, it takes you through tracking your goals and your mindfulness mastery, and it lets you build expertise as well. And what I really like about this program, I have a lot of clients who say to me, like, I tried to meditate, it doesn't work. And I'm like, well, what'd you do? They're like, I sat down with a 25-minute meditation. I'm like, nope, right? It's the same thing as, like, have you tried to run a marathon? Did you start with 26 miles? No, you start with, like, a short jog. So this protocol takes you through. Your first meditation practice is 1 minute long, and you build, because that's how we have to build our mindfulness muscle. So the first study just looked at how this app was being used in the wild. So no, the VA does not collect your data, but yes, it does collect some data. So and we looked at this data. It's not personalized data, but I'll show you what we mean by that. And the background here is that smartphones, right, they're ubiquitous. We need to figure out how to use them for good. But we really don't know a ton about what happens when people are just perusing the mobile app store, Android store, iPhone store, Google, Apple store. I'm clearly an Android user, Apple store. What happens when they download the app on their own? And then what? What happens next? So we just wanted to try to characterize how it's being used in the wild. So to do this, we took all of the anonymous download and mobile analytics data from unique downloads from Mindfulness Coach between August of 2018 and April of 2019. We just took one slice of time. And some of the data that we used included the star reviews in the stores, as well as the in-app assessment using the 5-facet mindfulness questionnaire short form, and some of the use data. So again, there are 104,000 unique downloads, more on Android than iOS. There are an average of 6,720 downloads per month. people really like this, at least those who go to review it really like it. Clearly not everyone. Usually people have a bone to pick or want to sing the praises on the reviews, but overall pretty good reviews, so we're going to go ahead and call that decently high satisfaction. But now when we look at app use, we get a very confusing picture. There's a tremendous amount of variability in how the average user will engage with an app that they download, that they find on their own and download. So the average time between first and final use was about 4 weeks, with a large standard deviation of 6.7 weeks. Average number of visits to the app was 4, large standard deviation of 8. The median here was 2 times. They visited the app 2 times. The average number of minutes in the app was about 16, again, an enormous standard deviation of 63. And the percent of people who used the app at least once after the first day of download was about half. We took a subsection of these to look at the high engagement users. So there were about 12,000 users who averaged 84 minutes or in the app and achieved a level 7 or higher. So in the app, you can do a training program where there are 14 levels. And so about 10% of the users achieved a level 7 or higher, which is a nice little subsection. And what's also really nice is that those who were using it quite a bit, we saw improvements in their mindfulness scores. So this is that it's this scale that essentially is trying to assess how mindful you are through these 5 different facets. And we saw a nice little correlation with increased use, improved mindfulness scores. So that's what we would hope, right? But overall, it's kind of hard to know what's going on other than there's a lot of variability here. And most people's natural inclination is to use the app infrequently for a short period of time. Many users never make it past the home screen. Most people don't come back to it after their first day of downloading. So it's this like, oh, I need help. I'm going to look and see if there's something. There's something. I'm never coming back to it. I would not call that particularly high engagement, but it's very typical of what we see in other mHealth apps. So this leads us to our next study, which is what happens if we do something in kind of, let's call it a hybrid environment. I like that. I've never thought of my study as a hybrid study, but it really is. So if we take folks into the lab, what can we do? So with this, we chose to focus on caregivers because, unsurprisingly, caregiving has a profound negative impact on those providing the care. We see a lot of elevated stress and anxiety and depression in caregivers, which has actually been documented to be quite a bit worse for dementia caregivers. They provide, on average, more hours of care than caregivers of other illnesses. There's a lot of increased anxiety and depression, probably, and a lot of grief as well, because not only are you providing all of this care, but the person you're providing the care for is often experiencing some massive personality changes and might not recognize you towards the end of the illness, and so there's a lot of additional distress that can come from providing care for someone with cognitive impairment and dementia. And what I think is really important, too, is that there's sort of no room in our healthcare system right now for the caregiver, right? When the caregiver takes these patients to all their appointments, but they're not the patient. And so there isn't a lot of room for them to get the help they need. And when they go to their own appointments, no one's giving a caregiver distress screener. There's no assumptions that things are hard. So primary care does not typically screen for this or address caregiver distress. So in a lot of ways, they're like this invisible patient population. So in this study, we're trying to determine the feasibility, acceptability, and preliminary efficacy of mindfulness coach for these caregivers. So we recruited 60 caregivers. We started recruitment in November 2019 and then ended in late December. I think we all know what happened right around the middle of that study, Mark. So for COVID happened. So obviously this is a massive confound. So I'll show you how I deal with it analytically because have to roll with the punches over here in research and clinical practice. So we did a baseline follow-up to 4 and 8 weeks, and we had additional data that was collected continuously through the app passively. So we used a special research version of the app so that we could get their data. Our population was primarily female, which is not surprising given that most caregivers are indeed women. Our caregivers were providing care primarily for their partners, so not a ton of adult daughters, which we see a lot of in caregiving too. Our caregivers were older. Average age was 61, and they were providing a ton of care per week. Again, a lot of variability there, but the average was 73 hours of care per week. Most were cohabitating with their patient, and we collected about a third of our data, about a third before COVID and then 2/3 during COVID, which was also interesting. So we had to switch our procedures a little bit, but it actually, I think, was better. It forced us to become totally virtual in recruitment and then make the study be totally virtual, so we got to roll with the punches there too, which was nice. You'll see why. So here's the 8-week acceptability and usability scale data. This is not the whole scale. These are just some of the nicer. All of the data was pretty similar, as you can see, but I just pulled a few of the example questions for you. So these caregivers liked this program. They found it really helpful. They were satisfied with it. And what I think is really important here is that they used it. They used it so much. So I want to back up a little bit and tell you, so we didn't just say download it and go. We gave them a brief 20-minute max, sometimes 15-minute orientation to how we suggested they use the app. So we showed them the training program that had the levels, level 1, level 2, level 3. Each level takes about 10 to 12 minutes to complete. We suggested that they do 2 levels a week. We suggested that they set an alarm so that the app reminded them to do it. And we made sure we had them download it. We showed them where everything was, and then we did a very brief test to make sure that they could, in fact, access all the different parts of the app. So it was a 20-minute training and a 20-minute we did a little bit of rationale building and buy-in building too. This is why you should use it. This is how you should use it. And they used it. So they spent about 3.5 hours in the app. And the average level achieved was level 6. And they visited the app an average of 29 times. So compared to that initial, and 80% of them were still using it in week 8. Compare that to the in the wild. And I get it, right? This is its own study, but I'm really, really encouraged by this because it suggests that with a little bit of a push and a little bit of training, 20 minutes from, my RAs were doing it, so that's, undergrad and master's level students, 20 minutes with them and they were off to the races. So that was extremely encouraging. And this is complicated, overly complicated. I apologize. We're modeling the effects of COVID. So the dotted lines are the pre-COVID folk, and the solid lines are the post-COVID folk. Suffice it to say that what's happening here is that at the end of 8 weeks, there was a clinically significant reduction between baseline anxiety on the hospital anxiety and depression scale, anxiety subscale. And at 8 weeks, there's also reductions in the perceived stress measure and in depression. So we're seeing the outcomes that we're hoping to see. That's a little bit of a cleaner. You see a little bit of a quadratic effect. Don't really worry about that. That goes away. And it's confusing, right? So, but it's still statistically significant from pre to post assessment. So the main takeaways here is that this pilot study was incredibly well received by the caregivers. We did qualitative interviews with everyone as well to get additional feedback. And even the folks who didn't use it much, they said that the reasons they didn't use it wasn't because they didn't like it. They just had a hard time finding the time. But even in the folks who didn't use the app as much, they said that one of the greatest benefits was knowing that it was there. We had several patients who, so this is kind of the limits of mHealth data, right? But we had several patients who said, you know, I did 5 or 6 levels, and then I was meditating on my own outside of the app all the time. So there's not an amazing way right now for us to capture what we want to happen, right? That is the result that is better than the data can capture, because the skills are transferring to daily use, and they don't always need to go into the app and listen to a meditation. They can do it on their own. And we had quite a few of our subjects say that they used the app, that after using the app, they had that skill transfer. So for my own for my own research methodology, I'm going to have to figure out how to capture that, because I think it's the most important outcome of these kinds of studies, and our data is not going to capture that as currently documented. We do have people estimate how much time they spend meditating in that 8-week program, so at the 8-week assessment, but I still don't think it's like a precise enough measure to I don't know, write home about at this point. But, you know, these are encouraging results. Does this work for everyone? No, not everyone wants to be on their phone even more than we're already on our phone. But having a little bit of relief in their pocket whenever they needed it was a huge asset for this particular population, who is short on time, short on resources, and is not traditionally helped by our healthcare system. So, yeah, the conclusion here is that we're really encouraged. This pilot proposal let me successfully apply for a larger study to study mHealth mindfulness in both patients with serious illness and their care partners. So we're in year 3 of that study now. And there's a lot more research to be done on sort of considering, well, what is the dose of this therapy that's needed? What is engagement, right? We don't know. We set fairly arbitrary benchmarks of engagement. We wanted folks to reach level 6. That was our hope, thinking that, you know, most psychotherapy studies will do 8 sessions, and if you attend 6 out of 8, congratulations, you are engaged in psychotherapy. We don't have those sort of dose-response analytics yet for mHealth mindfulness. So we're hoping to collect more data and try to figure out what is the optimal dose of mHealth. But for now, we're using the proxy of what's used for in-person psychotherapy. And we've got some more exciting research coming down the pike to look at how we can leverage these mHealth strategies that are less resource intensive and more scalable to get more folks the care that they might need. Thank you. Any questions? Any questions for anybody? We're going to open it up for questions.
Yeah, I have a question. So the VA pretty much saved my life when I was in severe bipolar crisis. But I've been working with the VA for 7.5 years now, and nobody has mentioned mindfulness coach. And I need it really bad. So this is a huge tip. Thank you. I'm going to start using it. But like, why do you think nobody has told? If they haven't told me, they're probably not telling, you know, thousands and thousands of patients who really need this, you know, this opportunity.
I think there's a big disconnect in how we implement and disseminate our evidence-based technologies and our evidence-based therapies, right? Like, there's a big push. I'm a psychologist by training. We've done so much great work over the last couple decades to figure out what the evidence-based treatments that truly work are. But when you do a broad survey of like what are people doing in their practice, it's not necessarily the evidence-based treatments. So like, the big push now is, okay, we know what works. How do we get it to the people who need it? And I think that's where innovative models with technology can be helpful. I don't know why none of your VA clinicians know about this. I don't know. I was a VA clinician who didn't know about this for a little while, and then I became a civilian researcher who learned about this. And it's wild, right? It's confusing, and it doesn't make a ton of sense, but it's very, very, very hard to effectively disseminate information. Although apparently very easy to effectively disseminate misinformation. So who knows? I don't know. It's tricky.
Thanks.
Yeah. Check it out. You can look up all of the VA mental health suite. There's some really great apps out there. Very, very user-friendly, very evidence-based. They really can move the needle for folks, especially if you're in between care.
Thank you all so much. I don't know if this is a question or more of a rambling, but I don't know, maybe we can think out loud. But when I'm thinking a lot about the caregiver, right, and to your point of how do we, get some of these tools in the right people's hands, these caregivers are very involved in, the person they're taking care of and their medical care, so they're at these doctor's appointments. They're in the medical system, but yet, that person they're talking to is not their doctor, right? So how do we think about getting tools like this to the caregiver? Should it be coming from their own PCP? Or do we need the geriatric psychiatrist to be recommending this? How does that all work when they're there as a supplement, but they're also in need of their own support?
It's a great question. I think about this from multiple angles. One is a policy angle. We need reimbursement for caregivers who are not necessarily patients of the clinician. But I think about this too from I had a baby 4 years ago, and when I took that baby to her first appointment, I got a postpartum depression screen at the pediatrician. I was not that pediatrician's patient. Now, I'm not really sure what would have happened if I had screened positive. I have no idea where sometimes these so I think screening is important. And I think screening initiatives sometimes die after the screen. So I don't know if they would have made a referral or not, but wouldn't it be great if every geriatrician, every primary care office who brought in a caregiver had a screening and referral program? But then the question is, referral to whom? Because there are not enough providers in the community. So it's all very, very complicated. But I think we have to build... It's the if they build it, will they come, right? I think step one is document that there are needs, and then step two is figure out how to meet the needs. Or maybe a population health perspective.
In the interest of what the last speaker said about, don't think outside the box. Imagine if there weren't a box. What if every caregiver were a patient? In the interest of wellness, right? Not because they're severely ill, but because they have unmet needs. So.
So I have some leeway over this because I'm the interim chief of geropsychiatry at McLean, and this is a story to your point. We built it. They're coming. The backstory goes something like this. About when COVID hit, we have a fairly large clinical trials program, and we had a lot of patients, people with dementia and their caregivers that were research trial subjects that were caught in this in-between where, they were not getting direct care, but they were part of trials, they were struggling, and there was no real resource for them. So we had philanthropy-supported time for a care manager, and she started this support group for people with dementia who were research participants. It was gratis, just public service. 6 months into that, she said that the people with dementia were engaged, but their caregivers, they felt that this had become almost family. And she used a word that ended up being transformative. She said, this experience has been therapeutic for them. And we kind of took that and it was can it really be so simple that we ask the caregivers if they're willing to register as patients, and then we can continue to do this, but now we can bill Medicare for it because we would make a diagnosis, do an intake, and they would get straight psychotherapy. And the 3 years since then, I've been waiting for the other shoe to drop, but turns out that, in fact, it is that simple. So we have a service now. It's called the McLean Caring for Caregivers service. It's in soft launch. Group-based psychotherapy. The caregiver is the patient. Caregiving is the social determinant of health. Turns out that we're still doing virtual, regular psychotherapy. We haven't moved to the app model yet. But I've talked to a number of people, including at CMS and the AARP. I'm can it really be this simple? And turns out it is, that we don't think of the caregiver as a patient, but if you do that, I mean, it doesn't solve the problem of not enough providers because you're creating even more demand. But what it's done is it's really simplified a lot of the dementia care. So these are not dyads. These are two individuals. We kind of uncouple the dyad and care for each of them separately. Some of them need psychopharm. The overwhelming majority don't. But we knew about the VA suite of apps, so I wanted to make a point there as well, that one wishes that some of the federal government built or the federal government supported products in digital health were better marketed, because we've polled a lot of our patients, and they love the VA stuff because they actually, it's not fancy, but they know that the guidelines protect their data because it's built robust. And same with most apps that were built with NIH support, in that there is a fundamental trust in something that was built with NIH money, because they know that they trust that NIH guidelines and the IRB is going to protect their private information. Which is a cool story that somehow no one is telling, that in fact there are areas where people trust the federal government greatly and will preferentially use it over something that's better looking and even easier to use and prettier. So it's an ongoing saga. We actually thought of doing a presentation on this at this TIPS. It's not quite there yet, so we're hoping we'll have more data. But the program is now in that stage where we're trying to wrestle with some of the questions you seem to have a better handle on. So we may reach out, how do you measure outcome of a program like this? What is the right outcome measure, et cetera? But, your point is well taken. We had the same idea. We've started building it out, and it's going well so far. And, sometimes maybe it really is that simple.
I'll just jump in here because someone said NIH. Two things I wanted to say, that there are two things. One, NIH and NIA has a huge program in supporting research in caregivers and dementia. It's a giant part of our charge. So if people want to do research in this area, they should let us know. Also, there was an AHRQ report a few years ago that came up about what are the known effective interventions for caregivers, and there's indeterminate, it got an I rating because there's indeterminate evidence. So that has only increased our desire to get a better, stronger documented evidence base in this area. And then the third thing I want to say is as part of that, we've also had been growing a program in what we've called triadic interactions, and looking specifically at what's happening in clinical care settings, both inpatient and outpatient, when people with dementia are coming in with their caregivers, and how are those interactions working with the clinicians. I think it's really interesting to hear about maybe one of the things that should happen is the dyad that comes in and then becomes a triad, the clinician should actually separate the dyad out into two separate care streams. And I'm not sure whether we've been looking at that or not in any studies, but it's just definitely an area of interest for us.
We should talk.
Okay, I think, are we good? Yeah. All right, thank you, everyone.